Thank you, chairpersons, and thank you, organizers, for giving me this opportunity to talk something CKD, which is not a very new topic, and most of us know more about CKD, but just a revision sort of thing. So, what is CKD? CKD term is used when we have a compromised kidney functions for over 3 months, and this is basically on the criteria of GFR, and we have the evidence of persistent kidney damage in any course. Then we call it CKD. And we want to differentiate from acute injury to kidney to CKD. CKD is a progressive condition that affects around more than 10% of the general population worldwide. In India, we have the data which suggests that our prevalence is rising, and it is between 13.24% of adults, with prevalence rising from 11 in 2017 to 16% in 2018 and 23. So it is rising, and basically we are not diagnosing it. That I will prove with my slides. The hidden burden, and the CKD is frequently missed in routine clinical practice, and this is missed just because of in undergraduate days in kidney function test more emphasis is on the serum creatinine level, which are very late to rise. That is why we are missing a lot of CKD patients. Up to 82% of patients with CKD stage 3 remains undiagnosed because they are asymptomatic. That is why they remain undiagnosed. Even in stage 4 and 5, nearly 50% remain undetected. That is the condition. That is why what we are seeing patients, it is only less patients we are seeing because they are not being diagnosed. So this is the condition. Every 1 patient in 10, and it is rising. The death, all-cause death, if you compare the death by the kidney disease, rising at 5th place from the 19th to 5th place. So it is alarming condition, and kidney functions and kidney disease are rising. In India, I have already talked about it is around 13%, but the problem is that the patient having raised creatinine more than 1.1, if we take the cutoff, then it is 8.4%. But if we take the CKD in terms of UACR, which is more good test to diagnose the early stage of kidney disease, it goes to 39.3%. That is why I said that serum creatinine level is not a good test to diagnose it. The complaints, usually patients do not have any complaints, but there are some typical complaints. If they are there, we have to suspect CKD very heavily, and I have noted here they are plenty, but they come only in the stage 4 and 5 and end stage renal disease, not in the beginning. And on examination again, we do not find anything in the beginning, but some alarming signs are here, and they will occur in the later stage of the kidney disease, not in the beginning. That is again a lot of things which are there, just not because of the CKD per se, they are because of the long-standing disease. And the clinical features, again, they will have almost every system involved, leading to the left ventricular hypertrophy, CHF, and having the lot of other problems related to GIT like anorexia and GI problems, neurological problems. And the hematologically, we will definitely have some signs which can be because of the CKD, and when we investigate it, we will definitely find them even in the middle of the disease. And then some symptoms which occur in the later stage of CKD, like pruritus and the volume overload and other things, they will definitely occur, but again they will occur in the end stage renal disease or stage 4 and 5 renal disease, not in the beginning. Investigations, complete thorough investigations are required. CBC is definitely required, but ordering CBC and interpreting CBC is a different thing. Most of physicians do not have the knowledge to interpret CBC better. CBC is being advised very often. And the urea and creatinine is always done, but they will rise later, and serum electrolytes and the ABG, etc., and the ultrasonography, they will determine whether we are dealing with primary renal disease or secondary renal disease. The renal ultrasound will decide most of the time whether we are dealing primary or secondary renal disease, and certain investigation related to cardiovascular system are also important. But diagnosis will depend upon, confirmation of diagnosis will depend upon basically GFR, and we will depend upon eGFR because calculating GFR is very, very difficult. Physiologically we can do it, but most of the time it's not possible, so we do eGFR. And we have to take also UACR. But here a caveat is there that if we have to take into account that CKD may have no albuminuria, non-albuminuric CKD, if we do only UACR, we will definitely miss it. So both UACR and eGFR should be done to confirm the diagnosis of CKD. The KDIGO 224 recommendations, 2024 recommendations are we must prioritize the screening for those with diabetes, hypertension, or cardiovascular disease and obesity conditions. So in these conditions, the patient must be subjected to UACR every 3 months, 6 months, or annually, depending upon the risk involved. Both eGFR and using the CKD EPI 2021 race neutral equation and UACR for accurate risk stratification must be done, not alone, which I said earlier. Continued importance of confirming CKD with repeat testing, 3 months to 3 months, every 3 months had to be repeated UACR done again and again. Underlying causes can be plenty, and never causes being identified. Awareness of kidney disease is relatively low, and basically in our community, including among the doctors and healthcare workers. Serum creatinine level, the widely advised and easily available, is a poor marker, which I said earlier, and most patients are asymptomatic to begin with. That is why we have to do screening again and again. In pathophysiology, we know that in step 1, basically starts with inflammation, and inflammatory infiltrates are there, and here the mechanism involved is basically inflammation. That is why in CKD, when it is stage 1 or step 1, inflammation is there, some good MRAs can work better because they will reduce inflammation and disease can be stopped there, or progression can be slowed down. In step 2, the intrinsic cell becomes compromised, and now the condition becomes almost irreversible and very difficult to control. Only progress can be halted. Step 3, the extracellular matrix is also involved, and here the condition becomes more severe. And step 4, the fibrotic changes have already occurred, and now it will definitely going to develop into ESRD. In pathophysiology, the glomeruli are involved, the tubules and the interstitium is involved, and the vessels are involved. Depending upon the conditions of the CKD, their involvement depends, and that varies from patient to patient. But all the three, glomeruli, tubules, and the vessels, they all are involved. The vicious cycle of nephron loss occurs. We know that we are born with 2 kidneys and around 3 million nephrons, but these nephrons are dying with age. By the age of 50, almost 60% of nephrons are left, 40% are died. By the age of 75, only 40% nephrons are left. With age, they are dying. And that is why the nephron loss is important. And the most common cause of this nephron loss in CKD was called as the acute on chronic glomerulonephritis, ACGN, in my country. So the initial nephron loss and then the compensatory glomerular hypertrophy, and in this particular stage, eGFR will be more than 100. So never confused by that. More than 100 EGFR shows that probably we are dealing with this condition, hyperfiltration. and this is not a normal condition. Then a vicious cycle is formed, more nephron loss in the coming time of CKD. And the risk factors for chronic kidney disease are type 2 diabetes, hypertension, cardiovascular disease, heart failure, obesity. These are the few important risk factors for CKD, and the non-traditional risk factors are plenty, including the age, the nephrotoxins, which is very, very important in my country. A lot of drugs are also doing that, especially Ayush drugs. They have a lot of nephrotoxins in them. Acute kidney injury, recurrent attacks of AKI, and the obstructive kidney disease, and the infections, different type of septic and other infections, environmental toxins, and the heat stroke, and the maternal fetal factors are important risk factors. The cardiovascular kidney metabolic syndrome, especially in relation to diabetes, this is very important because now we know the CKD, type 2 diabetes, and CVD are the mutual risk factors. If one disease is there, other two diseases will definitely be there. So we have to think in that direction. If the patient is having type 2 diabetes, we must screen for CVD and the CKD as well. The overview on the monitoring for progression of CKD based on the GFR and UACR categories. Here we categorize the disease on the basis of eGFR, and on that basis we categorize it from G1 to G4 and G5, and especially on the basis of UACR we again categorize it A1, A2 and A3, and depending upon that we classify patient whether more screening is required or frequent screening is required or some treatment is also required. So these are very important tools to decide whether to treat or not to treat, keep them under observation. GFR is the gold standard, I said in the beginning, and eGFR we done, and there are several methods, but the most important method I have already talked about. And the evolution of CKD, we again rely upon the eGFR as well as UACR, and that basis we decide whether we are dealing with the stage 1 or dealing with the stage 5 or end-stage renal disease. Assessment of vulnerable groups is more important, and these vulnerable groups require regular monitoring, and they are elderly people, those with malignancies, having autoimmune disease, having the renal stones, recurrent UTI, families with history of CKD, and low birth weight, and obese people, and users of NSAIDs, and young hypertensives. These are the individuals where we require more frequent observations. The role of the doctor is very important because we are the person who will diagnose them early, and early diagnosis can change their life as well, and depending upon UACR and the eGFR. Lifestyle modification is more important, especially diet, and some tips on the diet and physical activity, and they can change the shape of disease as well. Routine checkup, I said in the beginning, routine checkup we can find out the more vulnerable groups early, and we can diagnose it early. Lab test, again, the urine examination is very, very important, especially UACR. Other tests are already done, I have already talked about them. Those patients who have UACR between 30 and 300, they are the individuals where treatment will definitely have an impact, especially the newer non-steroidal, the mineralocorticoids. They will definitely have an impact on them because they are anti-inflammatory and they can change the disease burden. Diabetes, especially DKD, again, it's a more important cause, and we can diagnose them very early if we are vigilant and doing UACR very regularly in our patients of diabetes and hypertension. We can diagnose them very, very easily. Management depends upon the diet, lifestyle modification, exercise, the weight management. Weight is very, very important, and the smoking or tobacco cessation. Drugs are only few drugs which are being given depending upon the type of patient, ACE inhibitors and the SGLT2 inhibitors, the MRAs, especially non-steroidal MRAs, and GLP analog, depending upon the patient. So that will depend upon patient to patient. Control of blood pressure, control of lipid, and control of glucose is the key for the management. And symptomatic control requires more comprehensive control. For that, minimum drugs are required, more education is there, and implementation. And I will just finish it. Avoiding medications which can produce CKD or can enhance it, and also lifestyle changes. And the key takeaways are that we have to focus on early detection, optimizing treatment, and slowing disease progression as its prevalence is rising globally. Personalized guidelines, concurrent care, and that is important to control the CKD. Thank you. Thank you very much.